CHHABLANI, Endorsed Society Guidelines for Subthreshold Laser. Jay.
Hello, everybody. I'll be presenting our society guidelines, that is SOLS, Subthreshold Laser Society, Subthreshold Laser Ophthalmic Society. These are my financial disclosure. I am a consultant for ODOS, which makes microsecond laser, which is also a subthreshold laser. This is the guidelines which we published a couple of years ago in journal I. I'll quickly take you through these guidelines, but before we really reach to the guidelines, it is important that why do we really need guidelines for subthreshold laser? Because subthreshold laser has been here for more than 4 decades, because people were doing subthreshold laser almost 30 years ago. And I would say that, in spite of having numerous randomized controlled trials, real life studies, which have really brought this laser in the picture, like we heard from previous speakers, but unfortunately all these studies have a lot of variability in terms of the parameters, including laser, the thresholding weight, the titration part, the duration, and the spacing. So in spite of having so much data on subthreshold laser, we did not have any standard protocols. So that's why we are still in dilemma that whether this laser works or not, and what is the best way to deliver the laser. So what we did was we started a study to establish the guidelines for subthreshold laser among SOLS members. For this, we chose 12 experts who had more than 5 years of experience with subthreshold laser. We prepared 43 questions. In the first round, we got the responses in the masked manner. Then we organized 2 virtual meetings, and then we established the guidelines. And which guidelines I'm going to share with you, they are pretty independent of any specific laser device. And I can tell you that in SOLS group, the best part what I like is that we are beyond any industry or beyond any specific laser, because I work a lot with Nevilas, Lide works with Lumibird, and we have people who are working with Quantel. So it is actually putting all these things together and moving this subthreshold laser per se, and that was the whole purpose. So what we propose is that for diabetic macular edema, you can perform subthreshold laser for both center as well as non-center involving macular edema, with or without any conjunction with anti-VEGF therapy. We advise 5% duty cycle with 200 millisecond pulse duration, with 150 to 200 micron spot size, with no spacing between laser spots, using integrated pattern system. Each word has been really gone through a lot of discussion. When I say the second point, that remember we are using a 5% duty cycle, and we are actually not using any spacing, and we are using a pattern. So like Lita mentioned earlier, so we are assuring that when we say that there is no spacing, the pattern is assuring that the laser is done without any spacing, because it is impossible to do 891 in that fashion. We propose titration with 50% of threshold power, and you guys will be surprised that I'm standing here in 25 and saying this line so easily, but we have gone through this 50% threshold for almost 4 or 5 years. That's means when I started doing subthreshold laser in 2009, 10, and I used to do first laser, first do threshold power with continuous wave, then cut it to 30%, and there were like a lot of discussion around it, then rapid experiments. Then he finally came to the consensus that let's titrate with the subthreshold laser and then cut it half. You can perform the laser on the edematous area with subthreshold laser. However, it does not mandate any focal treatment of microaneurysm. Again, there is a difference compared to the continuous wave laser. We are not advising any specific focal treatment to the microaneurysm, because we believe the laser energy being delivered to the RPE is sufficient to actually help you to absorb this. Moving further into diabetic macular edema, the transfoveal treatment, like we discussed earlier, is treatment safe. We do not recommend any specific structural imaging studies, but if you want to sleep well, you are just starting, it is okay to get it done to make sure that you are not fried the fovea. So it's better that in the beginning do autofluorescence or OCT, document there is no structural damage, but we don't recommend that. We recommend to follow up in 6 to 8 weeks after subthreshold laser. However, repeat subthreshold laser is suggested after 2 to 3 months of initial application in case of poor response. I understand that this line has a lot of gray area because, like Anand beautifully showed you, multiple ways and the timing of the subthreshold laser with or without anti-VEGF therapy. But I think that DME is one of the very complex disease. So don't take this point, the third point, verbatim that I have to wait. But yeah, if your systemic control is good, you can wait. If it is not good, then you need to talk to the patient. We recommend anti-VEGF, conjunctive anti-VEGF for steroid therapy as per the physician discretion, because again, DME is very subjective. You definitely have to work with the patient. I don't think that even with anti-VEGF monotherapy, we have a blinded approach. We always work with the patient and figure out when to change OCT structures and many things. So we are not able to really give you computerized ways of deciding subthreshold laser, but these are guidelines to support you. Talking about CSCR, we spoke a lot about it. We offer subthreshold laser for both acute as well as chronic types of laser. Acute CSCR, because it is so safe, then why to wait for 4 months? If a patient has acute CSCR, give a month. If there is no resolution, you can do the laser even at month 1. So for chronic CSCR, we definitely support this as first line as well as in the combination therapy. Again, CSC is also a very complex disease because many times we have to put the patient on eplerenone. We have to do also, do yoga, stress therapy. So there is like a lot of pieces go in treating the chronic CSC. So when we are treating CSC, we are advising the same thing: 5% duty cycle with 200 millisecond pulse duration, 100 to 200 micron spot size, titration with 50%, and continuous, or I should say no spacing laser. Settings are pretty much same for both acute and chronic CSC. Transfoveal is safe, like we discussed earlier. For acute CSC, we are doing laser to the focal leak as well as to the adjacent area, because by now we understand that it is not just the leak area, but actually the choroidal structure surrounding area is also contributing. So for chronic CSC, we like to do both focal as well as diffuse hyperfluorescence areas on fluorescein angiography, just to make it a little simpler. One of the questions for Lite was that, yeah, there was a lot of leaky spots which we suspect on hyperfluorescence. So here we are advising treatment to actually the sick RPE. That's why you have to do a much larger area in CSR with a lot of complex RP damage. You can get autofluorescence or OCT just to document how the structural changes are, but you have to understand that the primary pathology is also contributing to these changes. So evaluation is in 6 to 8 weeks. If in case of poor response, we can repeat, and like I mentioned earlier, that the structural safety is so much that you can repeat micropulse laser. I have done micropulse laser for many patients 4 or 5 times in a year. This is just a summary. This is the table which Anand also showed. With this, I would conclude that these consensus guidelines do not suggest management of these disease, because trust me, among ourselves, we were like, okay, so we are not managing the disease for you. We are just advising the guidelines for the laser. So you have to definitely plan for individual patient, not to treat the disease, but to actually, these are just guidelines. To establish standard subthreshold laser application, because we really feel that once the whole community starts using a standard application of these laser, where we have standardized the protocol, that will give us the opportunity to understand whether how this randomized control trial globally will be used, which ethnic group is responding how, which stage, disease stage will matter. So I think we are still far from level 1 evidence, but this is really a one step towards creating a level 1 evidence. So if you guys are interested, go through this paper in I. Thank you so much for your attention.
Thank you, Jay. An excellent talk. I think he's kind of made it absolutely clear as to our guidelines and our philosophy going forwards along with the science. So does anybody have any questions further regarding that? Yeah, please. Can you use the mic, please?
Are these guidelines also for the green lasers or only for yellow?
Very good question. Yes, they are for both. They are for both. But we, in our experience, we have realized that now most of the devices are moving towards 577, right? I think everybody is moving to 577, so we will, eventually we'll have 577. However, definitely not apply these on 891. And that is one of the concerns we have about the place trial, is that 891 you cannot see the spot, but you don't know what you're doing. But here, we are using the pattern, here we are standardizing the protocol, so here we are titrating, so we know that what we are doing has some, when you step back and think, you will realize that, yeah, there is some sense to it. With 891, I still have challenge in understanding, what to expect.
So I like to make a comment sometimes. So one of the questions that I get is that if there's more edema, do you need to compensate for that? And the answer is no, because we're not treating that. The target's still the RPE, so just stick to the guidelines. And when we do the titration, it's in normal retina outside the arcade, so we're not,
Could you use the mic, please?
Can you take the mic, please?
Can you repeat the question?
How many spot burn in the one cycle for the CSO or something like that?
So we are
Spot burn, not spot sign, the power, something like that. How many spot burn?
No, that entirely depends. He's asking how many spot burns in one treatment sitting. So it entirely depends on the amount of edema and amount of area.
I do for the CSO, very good result, but maybe 60 spot burn. After 2 weeks, they have the chronic CSO, yeah. When it come
Please keep your mic.
1 year back to me, he's sick in 60, but I do the laser after 2 weeks, 6 and 9. So, but the spot burn, maybe I don't know because I never see, but I do maybe 60 spot burn, maybe more, yeah.
Yeah, so there's absolutely, see, as long as you're treating contiguously, as everybody has, kind of reiterated, it does not matter as to how many spots you have put in the macula. So as long as you're going again and you're not over retreating that same area in the same sitting. If you're going clean across in an organized way as the pattern laser helps you do, then it doesn't matter. It all depends, you may have edema this much, some other patient you may have this much, you may be treating bilaterally, one eye may be this much, one eye may be that much. So the number doesn't matter.
Okay,
right.
thank you.
I have another question. Do you have any experience in using subthreshold laser in cases like persistent edema in in BRVO, for example? Other cases? Thank you.
Sure. I don't know if Martin's going to talk about that, but yes, I have done that and I've found a beneficial effect. Of course, we don't have a randomized control trial to look at that, but yes, I think it can benefit. Yeah. Good question.